Okay. So we're talking about inflammatory disease. So you go, Danny, what do you think of this case?
All right, so we see T2 hyperintense or fluid sensitive sequence, hyperintense signal in the intermedullary
Okay.
mid femur and surrounding.
Periosteum here.
Yeah,
It's a 15-year-old.
15-year-old.
1 month of thigh pain. Here are the axial images, T1s.
T1. So again, on the left, you see
Little
periosteal,
here.
lots of signal there, and then thickening of the cortex or periosteum.
Okay, and then there's the good.
Oh yeah.
And there's the PD fat set.
PD fat set with hyperintense rim surrounding or periosteal, and then
Yeah, so it looks like there's some periosteal edema, some medullary edema there, maybe a little regularity of that cortical bone, like you said. Here it's very irregular. So what do you think this is?
probably
Penetrating injury, just pain for a month.
So since we're in inflammatory and infectious, I would think possibly osteomyelitis.
Okay, yeah, I think that's a good thought. Osteomyelitis. This was biopsy, and this was eosinophilic granuloma.
Okay.
So that's something else. And teenagers and kids, whenever you see bone edema and it's not obvious what the cause is, don't forget eosinophilic granuloma. It's more common than you think.
Okay, 22-year-old female. We have a femur. I'm not sure. Maybe is it okay? Sclerotic lesion in the intramedullary bone there, distally.
And this was chronic osteomyelitis.
Oh, okay.
No MR for that one. Sorry. Okay, Tayson.
All right, right thigh pain and mass. Not seeing too much on these radiographs.
I don't know, maybe something here.
Okay.
Here's the ultra noise in that area.
Some sort of cystic structure with some debris in it.
Okay. And the MR.
All right. That just looks like a cyst. I don't know.
Okay, and a little bit of funny stuff there. It's kind of subtle. Okay. So we can have a cystic structure there. I only see a single one, which and this is with contrast. There's not a lot of enhancement of this thing within it. So they excised it, and this was Csticercosis.
Oh,
Usually with Csticercosis, you'll usually see multiple lesions.
yeah.
So this is atypical. It wouldn't be come the top of my mind, but this was a case of Csticercosis with just a single cyst in this particular case. And as we already talked about, what is due to tapeworm, undercook pork. Okay. Robert.
All right, so we have a 72-year-old male, buttock pain with palpable mass for 1 month, known stomach cancer, post-subtotal gastrectomy in 2002. Looking at that left groin, there's a cystic structure, pretty thick wall there. I don't see a whole lot else. It looks like it extends medially relative to the ischiotuberosity. Could this just be like it's pretty extensive. Could this be like a bursitis or infected fluid collection?
Good. Okay, so this is what they excised, a little bit of skin there. And this was ischiogluteal bursitis with cyst formation. Right. So no infectious component to it.
66-year-old female with left hip pain for 5 months. So see a fluid density structure at the left hip with possible.
Here's some more images.
So cystic kind of structure with some internal debris or structures. Kind of in the myositis bursa region.
So what does this make you think of? Looks like it communicates with the hip joint.
Some sort of
Here's a T1.
little cysts in there, or
And this is a little atypical. I mean, one thing you can think about, maybe these are all loose bodies,
yeah.
but this doesn't really look like osteochondromatosis. That looks really more like soft tissue thickening, more like a synovial thickening. And this turned out to be lipoma arborescens. Synovitis with fat replacement within the tissues.
Okay. Coronal MRs in a young patient. I don't know. What side are we? Okay. Yeah, we see abnormal signal in the muscles on the, is that a T2?
This is a T2.
Uh-huh.
This is a T1. This is a PD fat set. So we don't really see a lot on the PD fat set, but maybe we're not anteriorly enough. But still, looks like all the muscles are really involved on the T2.
Mm-hmm.
So they did a rectal biopsy, and this is juvenile dermatomyositis.
Okay.
Okay, Taysom.
All right, so looks like diffuse increased signal within the musculature throughout the upper and lower extremities. Is this another case of dermatomyositis?
Yep. Good. Robert.
All right, so we have a 48-year-old female, general ache and skin rash after medication for 10 days. Has a history of sigmoid colon cancer, cervical cancer, and Mets to the liver. Again, it looks like there's a lot of increased signal throughout the anterior musculature, and
Yeah.
be another myositis case.
Yeah. Yeah. Good. Okay.
7-year-old female, pain after carcinoma. So looks like bilateral kind of symmetric increased signal. Maybe also a myositis.
Okay. You can see a lot of edema within the muscles. And hopefully you won't see this in more modern radiation therapy these days. But this is radiation-induced myositis.
"55-year-old female, acute onset severe hip pain. I see rounded low signal, the region of the gluteal tendon, could be calcific tendonitis."
Yep. Good. Okay, Tayson.
All right, right hip pain for 1 day. There's this mineral density.
Oops. Tayson, are you talking?
Yeah,
Oh, don't tell me it did it again. Why did it do that? Okay, Tayson, why don't you, can you hear us now?
yeah, I can.
Now we can hear you too. God, I don't know why it does
It's like
that.
there's this mineral density adjacent to the superior aspect of the acetabulum there.
in here.
Yeah.
Okay. Here are the MRs.
Mm. I mean, it's a low signal focus with surrounding edema within the muscle. It's just
Yeah.
calcific tendonitis of piriformis. Mm.
Well, here's the piriformis back there, but this is a gluteus minimus up there.
Okay.
Piriformis. And there's the calcium. Obturator internus maybe a little bit involved. Piriformis is there. Okay.
So it says superior.
It just shows all the complex muscles there, and again, calcific tendonitis involving the muscles there. Okay, Robert.
All right, so we have a 52-year-old female with non-draining ulcer and familial Mediterranean fever, and it looks like there's a lot of heterotopic ossification. It looks like correlates with the musculature of the thigh.
Okay, and here on the MR scan, we can see the low signal also within the musculature compatible with calcification. So what would you call this?
This would be like a myositis ossificans.
Yep, good. Okay, Danny?
All right, so we see some increased signal on the right with possible little cysts or bursula.
Here within the adductor muscles, looks like there's some focal low signal areas within it as well.
Yeah, so maybe
Here we can see on the coronal.
a calcific tendinosis at the insertion.
Yeah,
Good.
this is really within the muscles, so this was another
Oh,
myositis
okay.
ossificans. Good.
Older male with increasing hip pain.
Okay, so there's I think that's 4 months ago.
Okay.
Looking back at a study here. A little something there. Oops. And then here's a new study.
Yeah. New study, remodeling of that femoral head with edema. Could this be a sequel of like an inflammatory arthropathy with or were those nodules, rheumatoid nodules? Or no, that looks like a joint effusion.
Yeah, it's kind of a fusion, you're right. And so, I mean, it could be inflammatory, it could be infectious, so you'd certainly want to do an aspiration.
Mhm.
When they aspirated, they got pyrophosphate crystals back.
Okay.
So, pseudo gout.
Okay.
Hey, Tayson?
All right, chronic hip pain. See some
Right hip pain.
mineral density
Oh,
posterior
not
to
again. Says this thing does not like Tayson? God,
Wait, there's like a smart audio? Is there a way to turn that off?
where's smart audio?
Just all these choices here. Maybe.
Just noise removal and sync.
Okay, never mind. I mean,
Sync me then. I should really do that.
never mind.
Okay, I don't know. Oops, I don't want to do that. Tayson, why don't you talk? Let's see if we can hear you now.
Yeah.
Okay, we can hear you. I don't know why it keeps wanting to cut you out, but it seems to like to do that. Okay, here we go.
All right, so yeah, there's some mineral density in that right acetabular region.
Okay, right through there. Here, the frog leg view. So you want a CT scan?
Sure.
There's a CT scan.
Okay, yeah, some lobular calcific density
Okay.
in the joint space.
Okay, and then here's the MR.
Yeah, kind of heterogeneous looking, some sort of inflammatory
Right.
mass.
Yeah, it looks like inflammatory mass. I kind of think, well, could it be some sort of a synovial mass? Whatever. But this turned out to be CPPD disease.
Okay.
Okay. Okay, let's move on to kind of systemic inflammatory arthropathies like lupus, ankylosing spondylitis, and other things here. So, Robert, what do you think of this?
All right, so looking at that right acetabulum, it looks like there's a loss of the normal T1 signal there.
Okay. And here's the PD fat sat.
Yeah,
And
PD fat
increased
cell shows
efficiency.
increased signal, so edema
So, what do you think
primarily.
about?
Um, I mean, I'd be not entirely sure. Oh, this is post enhancement. It looks a little more serpiginous there.
Yeah,
Uh,
more peripheral enhancement, not central enhancement. So, it may not be an actual mass
yeah.
to
Uh,
influence. And it turned out that this was an infarct in a patient with lupus erythematosus.
okay.
So, osteonecrosis. Okay, Dan?
All right. 30-year-old male with sacrococcygeal pain for 4 months after injury. Then we see, let's see, some edema in the coccyx, sacrococcygeal region. Again, some edema there.
That's
Kind of,
stir something in the bone there.
yeah.
Here are the coronal images.
So on the right, we see, again, some edema in that region, the bone,
Yeah, it looks like it's both on both sides of
maybe
sacral.
sacroiliitis.
And then this was an MR scan 3 years ago
3 years ago.
of the spine.
So we're saying some edema of the facets and
So we're dealing with inflammatory disease.
yeah, so in this patient population, probably what's it called? Sacro ankylosing spondylitis.
Yeah, right, ankylosing spondylitis. So this patient's 27, so he probably had ankylosing spondylitis. Generally, it begins in the teenage years. So he'd probably had it for some time before. But, and here, this is kind of non-specific. It looks more like it could be traumatic.
Shorn
You
or something.
have to have a very high index suspicion for low back pain, especially in young males. You think about trauma, but you always have to think about ankylosing spondylitis because it's one of the most commonly delayed diagnosis lesions. And now, and here we can see these are the shiny corners that are characteristic of ankylosing spondylitis. It didn't really make a whole lot of problems when I was in training because you couldn't treat it anyway. You just try to keep people from fusing their spine and abnormal angulated positions. But nowadays it's a treatable disease, but you can only stop the disease progression. You can't reverse it. So the sooner you make the diagnosis and the sooner you treat it, the better the prognosis for the patient for the rest of their lives. And in the old days, it said, well, you should make the diagnosis before age 45. But if you wait till age 45, most of the time you're going to have substantial irreversible disease, which is going to leave the patient with a lot of debility. So this is a diagnosis you want to think about in the teenage years. Make the diagnosis early so you can stop the progression at a point where there'll be minimal symptoms. So it's an important disease not to forget.
Male treated orthopedist 2 years ago for low back pain, now 3 months bilateral hip pain. Radiograph of the L spine.
So a 19-year-old male, 2 years of low back pain. What's the one diagnosis you want to think about?
Ankylosing spondylitis.
Okay.
The spine looks okay in the
So,
SI
so
joints.
what you want to look for syndesmophytes, which I think we're probably going to, well,
Do it.
I don't know, in the lumbar spine lecture, so then there are the thin little calcifications of the posterior longitudinal ligament back here, which we do not see in this case.
Mhm.
They're actually late in the disease. There was a time when we thought they were early in the disease. That's before we had more sensitive ways to make the diagnosis. Look for the SI joints. They look pretty good here, right?
Mhm.
So what do you go to next?
MR. Yeah. Bone edema on either side of the SI joints.
Yeah, so
Worse
we have
than left.
bilateral sacroiliitis. We also have some inflammatory disease in the hips bilaterally. And there you can see the SI joint sacroiliitis. And he ended up having ankylosing spondylitis. This could be treated at a point where you want to treat it. And so I do have some more stuff on ankylosing spondylitis. Diagnosis, now you need to have sacroiliitis, but one other imaging feature, which I'll show in a minute. And you also look to see if they're HLA-B27 positive. If they are, then you look for two imaging features. Age less than 45, but you want to make the diagnosis at age less than 20 in this day and age. And these are the other features you can look for just inflammatory back pain, but other areas of arthritis. They can get heel enthesitis, you can get uveitis, dactylitis in the fingers, a lot like psoriasis. You can actually have psoriasis associated with it. Crohn's disease or ulcerative colitis. It tends to respond to NSAIDs, has a family history, elevated CRP, and the treatment really is TNF-alpha inhibitors in this day and age, which really stop the progression of the disease. It's expensive, but it stops it. So this was a study that looked at detecting sacroiliitis, and on average, MRI can detect sacroiliitis 10 years before it becomes X-ray positive. So once the X-rays are positive, one, you have irreversible disease because the X-ray changes are not reversible. But two, you've also missed the diagnosis for 10 years where the patient's been symptomatic and other parts of the body are being destroyed while you're waiting around to get a diagnosis. So really have a high index of suspicion for young, especially males, that come in with anything that could be like ankylosing spondylitis. Tayson, what do you think of this case? Oh, no,
Yeah, it
no,
looks like there's edema in the
Oh, my God.
sacroiliitis laterally.
What's going on here? Don't believe it. Really does not like Tayson. That's crazy. Okay, Tayson, what do you think here?
Yeah, edema at the SI joints bilaterally, so bilateral sacroiliitis.
Right. And then on the axial images, we can see this is more chronic, long-standing disease. You can see all these erosive changes of the subchondral bone. You like to pick up sacroiliitis before you get these erosive changes. And then a lot of eburnation here as well. So this is actually a pretty chronic, long-standing disease. And this was an ankylosing spondylitis. We would like to pick it up long before it gets this severe. Robert.
All right, looking at that right hip, looks like there's a fluid collection containing a lot of debris and synovial debris, basically. So, yeah, up there as well. Is that a
There's
hip
a
arthroplasty?
there's hip arthroplasty there. Here are the axial images.
looks similar. A lot of synovitis and synovial debris.
Yeah,
There's rice bodies and
right. And so these are turned out to be not bony. These are all rice bodies from chronic inflammation from a chronically loose prosthesis. Damon?
53-year-old male with bilateral shoulder and posterior thigh pain for 2 weeks. 8 months ago, neck pain, weakness, weight loss, 8 kilograms for 3 to 4 months. So
Yeah, and then a lot of
elevated.
elevated inflammatory markers.
They show some mild edema at the bilateral gluteal insertions,
Right?
and then actually at the lesser trochanters as well.
Okay, so he has enthesitis. So he's got inflammation and a lot of tendon insertions onto the bone, right?
Yeah.
Okay,
And over here, similar findings.
Here's the shoulder. You see a lot of kind of diffuse inflammation within the shoulder as well. Okay, so this looks like kind of a systemic inflammatory condition, and this turned out to be polymyalgia rheumatica.
Sixty-year-old male, bilateral thigh pain. So in the coronal images, we see edema in, looks like in the muscles. Yeah, in the gluteus maximus muscle.
It's and a lot of the insertion of the tendon here, right?
Yes.
So another enthesitis.
Yeah, at the regions of the insertions.
Maybe a little
Yeah.
myositis bursitis over here, and this is another polymyalgia rheumatica.
Mhm.
Tends to involve the pelvic girdles and shoulder, and it tends to occur in older individuals rather than a lot of the other rheumatic diseases which occur in younger individuals. And there are a lot of criteria for making the diagnosis that I don't want to go through here. This is more performed in the rheumatologist's office. So I usually just like to raise the issue of possible systemic inflammatory disease, and then it should be worked up appropriately. Okay, Tayson.
All right. Right lower leg mass for 5 years. Yeah, it looks like this ovoid heterogeneously calcified mass.
There's the MR. A little tail scatter. Kind of low signal peripherally, probably associated with the calcification. And then we have this central area, looks like a central mass.
Yeah. Is this some sort of heterotopic calcification?
Yeah, it could be a form of myositis ossificans. It looks like it could be in the muscle, but it's obviously chronic. It's been there a long time. Could be an old, possibly hematoma, but you expect it to be more cystic at this particular time if it's a chronic calcified hematoma. This turned out to be a hemangioma with a lot of thrombosis within it and calcification because they removed it surgically. Okay. Robert.
all right. So the history says long-standing renal failure. So, I guess looking at both hips, the joints look distended. Doesn't really look like fluid on the fluid sensitive imaging though.
Okay. Yeah, looks like a lot of kind of synovial thickening sort of thing, kind of that, but it's kind of low in signal. It's kind of like muscle everywhere. Longstanding renal failure. Here we can see all that soft tissue thickening of the joint space. Really, it looks like muscle in all sequences. What do you think this might be? And if someone with long-standing renal failure?
Would they be like, I guess, long-standing renal failure? I would think like calcium deposits, but
Yeah, well, here we can see that there are erosive changes where you have this in the neck. See these erosive changes?
yeah.
And this is amyloidosis,
Okay.
which you can get with chronic renal failure. Okay.
38-year-old male with back pain and left sciatica. So, pointing to some gluteal musculature, which looks asymmetrically thickened.
Yeah, asymmetrically here and here. And this is the piriformis muscles.
Oh, piriformis.
So the patient was symptomatic on the left, so it brings up piriformis syndrome, which is very controversial. There are people in the past in Southern California who felt that this was a shockingly chronically underdiagnosed condition. There are other people who feel that it doesn't exist. It's one form of it is typically seen with asymmetry of the piriformis muscles, where it's thought that the piriformis muscle may then compress the sciatic nerve, producing sciatic pain in that area. There are a lot of other muscles that can be involved, and then people feel that you can have the piriformis syndrome, but it doesn't have to be the piriformis muscle. It can be other muscles with asymmetric hypertrophy, which then irritate the sciatic nerve, producing symptoms. And there are a lot of different tests. None of them are really diagnostic. See, here's just this is an elite sprinter who had body pain on running, kind of normal MR of the spine and hip. And here we can see that there's in this case, a fibrous band. This is the sciatic nerve. It was thought to be that this muscle fascicle pressed against the sciatic nerve, producing compression of the nerve and piriformis syndrome in this area. And some of these people have actually gotten significant improvements in symptoms when they remove the offending nerve or fibrous band. And I think these fibrous band occur. I don't think they're very common. Certainly, I've been unable to make the diagnosis very often. I've suggested a few times. Again, you can see where the sciatic nerve comes down next to the piriformis muscle. Also, the sciatic nerve can have multiple fascicles, which can extend through the muscle, and that also is thought to possibly be a reason why you might have symptoms. So who's next? I don't know. Okay.
26-year-old female, pain along path of the sciatic nerve. Yeah, we see edema in that left piriformis muscle.
Yeah, so a lot of edema here. This may be due to overuse and muscle strain with edema or muscle tear. Much less commonly, it could be penetrating injury or infection. But here, the symptoms are on the same size as this significant edema within the piriformis. So it correlates with this. And I think the symptoms got better as the edema within the muscle improved in that case. Tayson?
All right, so it looks like edema of the right piriformis muscle and some increased signal within that sciatic nerve adjacent to it.
Okay. Yeah. See the nerve coming down here, the muscle there. And this was also thought to be a piriformis syndrome. Okay, Robert?
All right, so we have a 20-year-old male, right hip pain for 2 years, There's some ultrasound images and an MR of that right hip. And it looks like on the MR, it looks like there's a cystic structure anterior to the anterior musculature there.
Which is the same thing
Similar.
as this. Yeah.
Mhm.
Okay.
Um, yeah.
Okay. So that's then, and then the patient came back 9 months later, and this is what it looked like.
Looks like it's increased in size. It looks a little more solid than it did previously.
Okay. So, what's your thoughts about this?
Not entirely sure. I mean, it looks
Yeah.
fairly cystic on the MR, but
This looks cystic here. Almost looks like there's a tear of the fascia in that
hmm
area. So they removed this completely, and this was nodular fasciitis. In this case, now it had hemorrhage in it, which it didn't probably before. So this is nodular fasciitis. So this is just an area of inflammatory change that's extending through the deep fascia here. Okay.
All right, left hip pain. So left hip, it looks like you see some sclerosis in the
Okay.
left ilium, maybe head as
And
well.
here's a bone
Looks
scan.
like focal bone up or focal uptake at the left.
Okay.
Oh, yeah, left ilium and maybe focally on the left or right, um, like sacral lumbar spine.
Here's an MR.
Uh,
Normal side, abnormal
yeah,
side.
this is somewhat expensive. How
Abnormal side.
heterogeneous appearance.
Yeah. So what are you thinking about here?
Cancer. That's
So you got thickening. You don't really have a lot of edema or abnormal signal. You got thickened trabeculae here. The bone is expanded. A
um,
little bit of uptake on the. And this is in here. We can see on the X-ray. It just looks like a lot of thickened trabecular bone here. And on the bone scans, kind of mild uptake, but diffuse uptake there.
would you
Not a lot of signal change there, but clearly abnormal architecture to the bone.
Paget's look like that?
Good. It's
Oh.
Paget's disease. Very good.
51-year-old left hip pain and sciatica for 5 months. The left SI joint looks abnormal, left sacrum. Yeah, just
Okay.
it's SI joint looks like on these
Here's
T2 is it T2 or T1?
I think this is T1 up here, and this is probably PD fat set down here.
Looks like there's
That's a T1. That's T2
mhm.
sagittals here.
Yeah, I can't tell if that's edema on the
So
T2.
here you see all this in here.
Mm-hmm.
Looks like a lot of fat replacement,
Okay.
a lot of loss of trabecular bone in through here.
Mm-hmm.
These are other cases, same disease, but in the literature. A lot of thickened trabecular bone, a lot of replacement of the normal marrow by fat, and a Paget's disease. Marrow is variable. It depends upon the disease phase. In the early phase, it can be, you can have inflammation, and then later that it's the normal marrow is replaced by fat. Okay. Okay, Taysom.
All right, left hip pain is 70-year-old female. There's definitely some edema within and around the prosthesis.
Okay. And that's 11/23/22. This is CT scan a few days before.
Okay, looks like fracture around the femoral component.
And so it looks like we have a fracture coming down here. That's a little difficult to see on the MR because of all the artifact.
Yeah.
Okay. Good. I guess it's not inflammatory, but worried about it. Okay, Robert.
So we have a 39-year-old history of bilateral total hip arthroplasties 5 years ago, left ceramic break and revision 2 years ago. Uh, hmm.
Okay, so this is June and this is October.
Okay. And is there maybe a loose body in that left hip now? But otherwise, I don't see a lot of difference. Yeah.
Okay, here's October, November, then we go to March and then July.
Yeah. Okay. Now I see some progression. There's a lot of extra calcification and heterotopic ossification there. Debris.
Especially you can see it nicely here.
Mhm.
Very asymmetric, not there really before. So we get progressive, really, what looks like calcified, dense, soft tissue here in the joint space. Okay, here's what the MR scan looked like.
Let's see. MR, there's a lot of susceptibility artifact.
Actually, I shouldn't have said calcific. I didn't mean to say that. Strike that from my statement.
All right.
So what do you see here?
There's a lot of susceptibility artifact, I think is probably related to the hip prosthesis. I'm not sure if any of that is related to maybe some calcification as well. It is a little more pronounced than the other sides.
So they went into surgery and this is what they found.
Yeah, looks.
So we got some motor oil in here
Yeah.
and a lot of pieces of soft tissue that are covered really with metal deposition. So we don't see this. I haven't seen this in a number of years now, but with the new prosthesis. But this is metallosis, where you get shavings of the prosthesis, metal from the prosthesis out, produce inflammatory disease. You get these large collections of fluid with metal in them, and that's what it looks like. So again, I haven't seen this in a long time. This is 2007. Okay. So when you image the post-op hip, you try to use a technique to minimize metal artifact. And the things you look for osteolysis around the bone right next to the prosthesis, as well as you can see it. You look for synovitis, obviously infection, hemarthrosis, fracturing, loosening, heterotopic ossification, tendinopathy in the area, neurovascular impingement, metal on metal with metallosis we talked about, AVN, and aseptic lymphocytic vasculitis, which is a large soft tissue inflammatory mass surrounding the joint. So kind of the differential you got to be thinking about when you do this post-op imaging. What of these imaging findings will actually correlate with pain? Again, there are many studies that have showed bone marrow edema is one of the best correlators with pain. It's not perfect, but it tends to be a pretty good marker of pain. Ductal tendon tears tend to be associated with pain, but there's no real correlation between pain and the presence or site of a pseudotumor, which are these large soft tissue masses that you can see. And then there are a lot of potential causes of synovitis with arthroplasty. Fortunately, over time, we've learned lessons from a lot of devices that can produce hypersensitivity reactions, and now the current prostheses have very low rates of development of synovitis, and always be concerned about infection. Okay, who's next?
With pain 2 months after hip replacement. Surrounding this hip replacement, there's a lot of bone change, some erosive change of that acetabulum, large effusion. Yeah. Okay. And effusion with debris or synovial thickening. Oh. Contrasted study, there's enhancement of could there be an infection?
Yeah, when you see this, it really looks like kind of an abscess with rim enhancement, a lot of inflammatory debris in here, and this was meth-resistant Staph aureus infection.
Okay.
Now, one of the findings that correlate well with infections, if you see periostal reaction, capsular edema, and surrounding intramuscular edema, those are all tend to correlate with infection. Okay,